Welcome, everyone. I'm Dr. Chris Scuderi, and over the last year, I've had the pleasure of chairing the FAFP's COVID-19 Task Force. Tonight is the first FAFP COVID-19 webinar for 2021. This evening's webinar represents the 14th installment of programming organized and presented to support Florida's family physicians and their staff in dealing with the COVID-19 crisis. Tonight's presentation, COVID-19 Updates for Family Medicine 2021, Testing, Treatments, and Vaccinations, will feature two highly respected family physicians whom we are lucky to have in the state of Florida. First of which is Dr. Daniel Van Derme. Dr. Van Derme serves as the Senior Associate Dean for Clinical and Community Affairs at the Florida State University College of Medicine. Dr. Van Derme is also a past president of the Florida Academy of Family Physicians. Our second presenter is Dr. Julia Weeks. Dr. Weeks currently serves as the Associate Residency Director at Tallahassee Memorial Hospital's Family Medicine Residency Program. So as you can tell, we have a very accomplished panel to lead tonight's webinar. The FAFP designates this live activity for a maximum of 1 AMA Category 1 credit. To claim credits, please complete and submit the activity evaluation. An evaluation link will be emailed after this webinar. Only FAFP members will be eligible to receive credit for this webinar. Before we begin, remember that similar to all FAFP webinars, participants will be in listen-only mode, but you can type questions in the Q&A box located at the bottom of your screen that your presenter and I can see. We will attempt to answer your questions either during or at the end of this presentation. Okay, let's get started with tonight's presentation. Dr. Van Derme and Dr. Weeks, welcome.
Thank you.
Thank you. Thank you, Chris. And welcome, everybody. Hopefully we'll give you some good and useful information. As we know, this stuff changes on a day-to-day basis, including during this conversation right now, there's probably new information that's breaking live somewhere about something. So we're going to do our best to give you some good, useful information going forward. As you can see, have no disclosures to report anything in terms of financial conflicts. But we have to also declare off-label use, which is virtually everything that we talk about with COVID. It has not been FDA approved. All of these various treatments, vaccines, et cetera, fall under the emergency use authorization, which is in fact a somewhat lower standard than FDA approval. But it's based on the best available evidence that we have. And that's the sort of thing we're going to talk about. So next slide, please. We're going to talk about some of the testing issues that I will cover. Then I'm going to turn over to my colleague, Dr. Weeks, who's going to talk more about treatment issues. And then she'll kick it back to me when we talk about vaccines and vaccination status as well. Throughout this talk, you're just going to hear us use the shorthand COVID. COVID is the illness caused by the virus, COVID-19 or SARS-CoV-2. So just kind of put it in context when we start tossing on the word COVID, just to make it shorter for all of us. Next slide. So just a few very basic facts that hopefully most everybody is already well aware of. Incubation period for this virus is about 5 days, but it's got a big range. That 2 to 14 day period, that's why we have that 14-day quarantine for those who have been exposed to it. We are, like many viruses, found to be most infectious a couple of days before actual symptoms occur or before a positive test. And that's why contact tracing goes back 48 hours before that test was done to see where people have been. You can see our symptoms that, again, hopefully most everybody is very familiar with. The one that stands out, that loss of taste and smell, is highly specific for COVID. Very few other things will cause that, but everything else can be from any virus. Anything can cause fatigue or sore throat or congestion, et cetera. The official symptoms you'll see there, but a number of others are also maybe added to that list, including abdominal pain, rashes, dizziness, et cetera. But for now, the top part has the CDC symptoms on it. Symptoms, you'll see two different terms that are tossed around as far as symptoms. So we know that about 30%, and some studies say as high as 40%, have no symptoms at all. And then you hear about but 80% of the people have mild symptoms. So that's 80% of the 60% who have symptoms. So overall, out of 100 people with it, about 30 to 40% will have zero symptoms, and about 60% or so will have symptoms. Of those who have symptoms, you'll hear later, about 80% of those, it's very mild. And then we start dealing with that, 10% or so that wound up getting very sick with it. And that depends a lot on age, comorbidity, severity of illness, et cetera, et cetera. Next slide. So testing, there's a number of options that are out there for testing, and these are messages that we need to reinforce for our patients repeatedly. As with a lot of these things with COVID, there's way too much misinformation out there, way too much garbage on social media and on the internet. I heard from my neighbor's cousin's friend that, my test was good for the next 2 days or whatever that way. We remind our patients that when we do these tests, PCR or antigen tests, that it only tells us about that one spot in time. There's a huge surge of people getting tested right before Thanksgiving, right before Christmas, because they wanted to know that it was safe to visit with their relatives. But that really doesn't tell you that. All it tells us is at the time the test was there, we couldn't find it, but it could have been percolating. Someone may have been tested on their second day after exposure without any virus growing, but by the time they see their relatives 4 days later, they are infectious and are spreading it that way. If someone develops symptoms, none of our tests are perfect. There's both false positives and false negatives. So if someone develops symptoms after a negative test, they need to get retested. They shouldn't say, well, I got tested a couple of days ago and my COVID test was negative, so I think this headache, fever, and malaise must be from something else. No, they really do need to get retested. Again, it may have been that first test was just a couple of days too early before we were able to predict it that way. And we also know about this problem with persistent positive tests, particularly with the PCR test. CDC says do not get retested up to 90 days after infection because many people, not all, but many people will continue to shed what is sometimes referred to as dead virus or dead virus particles, and they show positive even though they're no longer infectious. However, some people clear it very quickly. So it is not a valid test to say whether they had a prior infection. They said, well, I had this thing a couple of weeks ago. I think maybe it was COVID. Let me get one of those PCR tests and find out if it was. No, you can't count on a negative PCR to say what that prior test was. Antibody tests are problematic. We'll get to those more in just a second. So who do we test? Obviously, anybody with symptoms of COVID. Any of the close contact, this changed over the last few months. It used to be a continuous 15-minute period. It is now a total of 15 minutes. So yes, 5 3-minute exposures in a day means you had a close contact with somebody with COVID. After a high-risk activity, large gatherings, family gatherings, weddings, funerals, et cetera, and obviously we do the mass screening just to let us know what's going on in the population and to control the pandemic. Next slide. So when is the best time to test? Obviously, a symptomatic test, and at the time of symptoms and the test is done and it is negative, then it is pretty unlikely, not 100%, but it's unlikely that it is COVID. If they've been exposed because of the incubation period, it's recommended to wait at least 5 to 7 days. And some say, well, you should wait 8, 9, or 10 to really be sure to give it a full incubation period. But generally speaking, if you test them on day 5, 6, 7, if what they were exposed to gave them COVID, then you're going to find it in your testing. If they tested positive 2 days after an exposure, they probably already had the COVID prior to that exposure. And again, as I mentioned earlier, not within 90 days of a prior test because of that problem, again, with the persistent dead virus, particularly with the PCR, much more than with the rapid antigen. Another change occurred back in December when the CDC changed its guidelines about being able to test out of quarantine. The standard recommendation from the CDC remains that it's after 14 days since the last close contact. And I'm going to touch on this after for just a second because it's one of the most confusing things that I've seen among the countless patients that I've dealt with. As a context, I've been managing or directing the FSU COVID testing and now the vaccine program since this nightmare began, and have had over 55,000 tests fly through my hands in one form or another, and I've had to talk to a lot of positive people, et cetera. So one of the common things that confuses people is they think the day that the test was done is their first day. That's day 0. The day of the close contact is day 0. And then you start counting a day after that. The next day after the close contact, they've now had 1 day post-contact. If somebody had a positive test on Tuesday, Tuesday is day 0. Wednesday, they've had 1 day. Thursday today is they've now had 2 days. And after the 14th day, in other words, on the 15th day, they get released from standard quarantine. If they're infectious, it's that 10 days of isolation. And on day 11, after that 10th day, they can get out. So here's what changed with a quarantine option is if somebody has now been monitoring their symptoms closely and have had no symptoms within 10 days after the 10th day of close monitoring, they can be released from quarantine early. And the CDC says, yes, a very few people will slip by, but their recommendation is that that is a reasonable and acceptable risk for the very small chance that they may slip by on day 10. The other option is to get a PCR test on day 6 or 7 and get released on day 8. Again, it must be a PCR test, not a rapid antigen, but after 7 days of close monitoring, they get a negative PCR test, they can get released on day 8. So those are your test timing issues. Next slide. Now let's talk about how we do our testing. The test of choice is clearly the PCR test. It is by a significant margin the most consistently accurate test that we have. It can be done as a nasopharyngeal swab. I certainly did a whole lot of those. Everybody hates them. I refer to them as tickling your brain with a swab that goes way in there. And then thankfully, back in the fall, the CDC changed it and said that an anterior nares swab, or from the front of the nose, will also give us an adequate specimen, and the patient can collect it themselves. The key is you should warn your patients, and if you're doing this testing yourself in your office and sending it off to Quest or LabCorp, you need to swab very, very well. Swab around 5 times at least in each nostril to get plenty of material on there. Otherwise, what you will get is an invalid test. And we see that sometimes if somebody does the quick in and out swab, and what the lab does, it says, is there enough other human DNA in there to say that it is an adequate specimen was obtained? If not, you get an invalid, you got to retest them. Saliva tests are starting to be done by some labs, not as commonly done, may become more available, and there's some potential options out there for a very inexpensive saliva test, but again, not yet widely available. Generally speaking, this PCR test is going to be 99.8 or so % sensitive and 95% specific. And to interpret these, people say, well, how many false positives will I have? How many false negatives? The question is, who are you screening? So if you're doing a mass screening and your community rate is down at about 5%, then the math plays out that you're going to get about 3 out of 100 are false positive and about 3 in 1,000 are false negative. But lately in Florida, we've been running closer to 10% across the state, higher and lower in different communities. And in that case, obviously, we're going to interpret it differently. If you get a positive rate, then you should believe it more. But you can still have 2 out of 100 as false positives. And you're going to have even more false negatives. So your false negative rate is going to go up if you've got a high rate. If you've got somebody that's got symptoms and they've been exposed and your pre-test judgment says, oh, there's about a 50% chance this person's got it, then you're going to have rare false positives, 2 in 1,000. And you'll have even more, 5 out of 100 false negatives. So the bottom line is if your clinical suspicion is in that intermediate or high range and you get a negative PCR, look at repeating that in 24 hours so that you can really be confident, because you can still get false positives and negatives. For people who don't believe their positive test, and that still happens, maybe it was a false positive, and you may be right. I've had countless patients who said, so they went and got a rapid antigen test and it was negative, therefore the PCR must be a false positive. Wrong. And if they went and got another PCR test that was negative, they want to believe the negative and they say the first one must be wrong. No, I tell them you've got a 50-50 chance. One was positive, one was negative. You need a tiebreaker. And they should be PCRs and greater than 24 hours apart. Timely results can be a challenge. You've got to know what's going on in your community, whether I can get those results in 24, 48 hours or whatever that way. Next slide. The antigen tests specifically are designed for symptomatic patients, but they're increasingly being used for widespread community surveillance. Good news, you get results in about 15 minutes. The bad news is you sacrifice sensitivity in particular. So although false positives are rare, false negative tests do happen a significant amount of the time. 20, 30% of the time, it's going to miss it in somebody who's already got it. So if you've got a symptomatic person and their rapid antigen is negative, all the guidelines say you've got to follow it with the PCR. You can't believe it. Next slide. And this shows up very nicely in this CDC algorithm. I encourage you to look that up if you're using rapid antigens. And as you can see, it depends on whether they've got symptoms or not. If they've got symptoms, they test positive with an antigen, they've got it. You isolate them. If they have no symptoms and no exposure at the far end of the spectrum, you can say they're not infected. That's that green zone. But in between, you're still going to quarantine people with a negative antigen test if they've had a close contact, even if they don't have symptoms. You can't believe rapid antigen to release them. They still must quarantine. So I encourage you, if you're using rapid antigens or you're interpreting them, keep this algorithm handy to kind of help walk you through what to do with those patients. Next slide. Antibody testing is a mess. That's the bottom line. Very tricky, rarely necessary. There's a big problem with cross-reactivity with other benign coronaviruses. So they can test positive with it and they've got another coronavirus that's not COVID. It doesn't help us with managing an active infection. The antibody levels are way too variable. Some people, they climb quickly within a week. Some, it may take 3 weeks or longer. They clear at varying rates. Some people can drop their antibody levels below a detectable range very quickly. Others will hang on to the antibody levels for a long time. And the bottom line is we don't know how much antibody it takes to protect. We know that for other things. We know how much. We can say that your hepatitis B surface antibody is too low and you are not protected. We don't know that for COVID. So in some people, we just never do them. In some studies, they've tested people with a documented infection, test them every 48 hours and never found detectable antibody levels. So it really is all over the map. And the antibody tests themselves sometimes check for the nucleocapsid, sometimes they check for the spike protein. It really is a complicated mess. And we'd have to spend a whole hour just on antibody testing alone to sort through it. So instead, I'm going to turn it over to my colleague, Dr. Weeks.
Thank you very much, Dr. Van Dermy. And we'll get back to him in just a few minutes. Next slide. I don't have anything to disclose except the fact that I did an incredible amount of research and study, and I hoped to bring you much more valuable information than I am bringing you. But I'm going to give you what we have available at this time. Next slide. We're going to breeze through what is available for outpatient treatment of COVID, but remember, we're family docs. So treatment doesn't just have to do with giving a medication. I'm going to emphasize the importance of prevention and the importance of promoting health during this pandemic. Also, having that system for contacting and managing patients goes so far to alleviating the extra stress they have having this disease that there's still so many unknowns about. We've utilized decision trees, algorithms more than ever, and we'll briefly touch on that. Then I will get to a brief review of the medications that have been used. As Dr. Van Dermy said, there are none approved. And then I'll bring up a controversy or so in the management. Next slide. So remember, don't get hung up on the statistics, please. There are approximately 80 to 85% of patients have mild enough illness that they don't warrant medical intervention or hospitalization. Dr. Van Dermy's slide had a slightly different percentage, and it depends on the details of that. So just don't get hung up on that. The majority of patients don't need us to intervene medically, but most patients don't know that. So how do we manage them? There's a lot of good self-care advice out there from CDC, NIH. There's a lot of junk, as Dr. Van Dermy mentioned before. We've used telehealth more than ever before to reach out to those patients with symptoms who did not need to come into the clinic for evaluation, into your center's offices, and that has gone, that's really helped patients immensely. It's important to know who needs to go to the hospital, so that will be partly what I'll deal with. Next slide. The problem is this is such a complex illness that there's so many variations in the presentations, and we are in the middle of respiratory season, that it confuses the issue. But I'm going to focus on just what do we do to manage our patients who are acutely ill in the outpatient setting. We're recognizing more and more that there are a certain population of people who have COVID who develop ongoing chronic symptoms, and we will need to learn to deal with them better. Those are the long haulers. The bad news is there really isn't any magic treatment or cure. I wish there were. Next slide. But remember, we are not helpless in this. We have felt helpless for going on 9-10 months as we waited for this to come and as it hit, but we aren't. We can help prevent this illness. And this prevention is a basic tenet of family medicine. Avoid the illness, prevent the spread. We haven't done a great job of it, but we know we can continue to help that. Wearing masks, socially distancing, using good hand hygiene, encouraging our patients to get vaccinations. But don't forget, it's not just the COVID-19. They also need their flu and pneumonia, because if they get the two together, one or the other together, it makes it a lot worse. We can encourage our patients to improve their baseline health. Next slide. The lifestyle modifications that we recommend on a daily basis to improve patients' health have also been shown to strengthen the immune support. So we're faced with an illness with no definitive treatment for outpatients. We can convey to our patients, there is something you can do. There's something you can do to help your body not get it. There are things you can do to help your body do well if you do get sick. That is, control your blood sugar if you have diabetes, improve the control of heart failure, hypertension, COPD. This is a great time to quit smoking, encourage weight loss, or even just improve nutrition, moderate alcohol consumption. I'm not saying drink moderately, I'm saying moderate, limit alcohol consumption, getting adequate sleep, managing their stress, managing our stress, helping our staff manage the stress of all that's going on around us, and then getting regular, moderate exercise. All of those have been shown to help strengthen our immune systems. Next slide. Yeah. There have been incredible new demands on our offices and health systems that have been so incredibly challenging. And there is a lot of good information on the CDC website, and many, many university systems have come up, lots of hospitals with their own. But we had to create new systems for triage and managing these patients. Questions, people were calling with questions who would have never called before. So we had to train staff, train them how to use the triage decision trees, which in the first few months seemed to be changing almost daily. We needed to learn how to deal with the patients who are sick and help them manage themselves at home. Again, using decision trees and triage protocols. And what we found is regular contact with our patients when they are homesick with COVID, even if they're not terribly ill, has gone a long ways to reassuring them and helping them know they can get better through this. We've had to dedicate separate space, separate buildings. In our case, other people have just been able to dedicate a few rooms and train staff to put on and take off PPE appropriately to see the patients who have symptoms that could be COVID who come into our offices. Next slide. Skip this one. Just next. We've used these triage call lines, and offices that didn't even have as many now have them. And these call lines have been a lifeline for all of our patients. When we started ours at Tallahassee Memorial, our COVID hotline initially was staffed by family medicine residents and nurses from the Family Medicine Center. This is a picture of our initial hotline, and I just want to say our workstations were 6 feet apart, and we wore masks down there. They just removed them for a second for me to get that picture. Next slide. So who can be managed as an outpatient? Initially, We hospitalized anyone with respiratory symptoms as we're anticipating progression. And now as this has gone on, we really emphasize and stress managing most patients, even those with significant comorbidities, as outpatients, unless or until their symptoms warrant admission. Next slide. This is an example of the basic self-care instructions for patients, which is available on the CDC website, which we've made available on our patient portal, so have many others, just so patients can have access to what we consider reliable information. Next slide. Next. When do you need to make sure the patient gets in for medical care? And this is something we emphasize with our triage nurses, and I hope you do every day. If you get any of these signs, this is direct from the CDC website. If you have trouble breathing, persistent pain or pressure in the chest, new confusion. So remember that many of our COVID patients have been elderly, so we want to make sure it's new confusion, not just their normal confused state. Inability to wake up, they get somnolent, or they're starting to look cyanotic. They need to go to the ER. Next slide. We have a very limited pharmacotherapeutic arsenal, or I could say non-existent. The Food and Drug Administration has approved one drug, one medication to treat COVID-19, and that's only in certain situations and only in hospitalized patients. That's remdesivir. It's not for our talk tonight, but that's the one that's been approved. Next slide. We do have antibody-based, COVID-specific antibody-based therapy. Among the treatments that have been evaluated, it's the only therapy that has shown some potential benefit for certain patients, but the data is still very limited. It requires IV administration. It has to be given early in the illness for it to be effective. So administration is logistically very complicated in many of our outpatient settings. Next slide. This is directly from the NIH treatment guidelines, and this is for non-hospitalized mild to moderate COVID-19. And the treatment guideline panel says there's insufficient data to recommend either for or against using the specific antiviral or antibody therapy. So even though we have bamlanivimab and casirivimab plus endimivimab, they're not recommending against, not for, but we do have an emergency use authorization for them. Next slide. It's not FDA approved. The EUA is for non-hospitalized COVID positive patients with increased oxygen requirements and who are at high risk for severe COVID-19 or hospitalization. It's a single dose, IV 700 milligrams, and it works best the sooner it's given. So as early as you have a positive test and someone begins to decompensate, if you can get that in them, certainly it must be given within 10 days of symptom onset for it to be effective. Next slide. The search for clinical guidance, it's been disheartening to continue looking, searching, and find little or nothing available to help our patients. There are many studies that have been deemed inadequate, some evidence of unethical practices in research in order to promote one thing or the other, and strong polarizing voices, including within the medical community. The reality we're faced with is that we've never been in this situation before. This is a pandemic of a magnitude we've never seen, and it's difficult to handle just this high degree of uncertainty surrounding this viral illness. We need to accept that, face it. Next slide. Treatments that are not recommended, hydroxychloroquine with or without azithromycin. This is from the NIH guidelines. Again, there's conflicting data. The hydroxychloroquine alone has not been shown in reliable studies to have benefit, but the quality of data for any of the studies has been questionable, and we do have the risk of QT prolongation. Ivermectin, when I first put this slideshow together, the NIH recommended against using it, and they dropped that about 12 days ago. And then ivermectin is a drug we all know. It's an antiparasitic drug. We know it more for some of our animals, but now the NIH says it can't recommend for or against its use, leaving the decision up to physicians and their patients. Dexamethasone is advised against by both NIH and World Health, or any corticosteroid in treating patients who are non-severe unless they're already on it for another reason. Next slide. This is one of the studies, there are many studies out there demonstrating some benefit of the combination of hydroxychloroquine and azithromycin. And this is a study from Iraq that shows that it's been helpful to promote the recovery of most patients and reduce their signs and symptoms significantly, that they experienced very few, but they were manageable side effects, mostly related to the heart rhythm. And their summary is basically, in the absence of FDA-approved medications to treat COVID-19, repurposing hydroxychloroquine and azithromycin to control the disease signs and symptoms in outpatients can be useful. Next slide. I am not reporting on the reliability of that study, by the way. So another thing we hear a lot about is, do we need to anticoagulate our patients? Do we need to treat or prevent? Do we need to test them to know whether or not they have increased coag markers? And the answer is no. In non-hospitalized patients, there's no data to support that. Next slide. No data to support the testing of the prothrombin, fibrinogen, but there's all, and D-dimers. There's also no data to support treating them, and shouldn't be initiated. The recommendation from NIH is that we shouldn't start anticoagulation or antiplatelet therapy to prevent venous or arterial thrombosis unless the patient has another indication or is participating in a clinical trial. Next slide. So Up to Date, which many of us use regularly, gives us a little bit more guideline about the anticoagulation. Even though it is not indicated in most patients, it may be appropriate in select individuals with COVID. Those with other thrombotic risk factors, such as a previous venous thromboembolism, recent surgery, trauma, or immobilization. There are some who are also recommending it for certain cancer patients. If it's used, if you make the decision to utilize and anticoagulate someone, they recommend a regimen such as rivaroxaban, 10 milligrams daily for 31 to 39 days from the day you start the therapy. This recommendation against routine anticoagulation is based on several expert panels and based on the data that we have so far, that there's actually a lower risk of DVT or PE in outpatients and people who have mild to moderate COVID. It's a lower risk. We have to weigh, as we always do, the risks and benefits. But here again, we're lacking published trials. That's because we really haven't had time to get to those yet. Next slide. These are the other recommendations from NIH. For vitamin C, insufficient data to recommend for or against using vitamin C to treat in the non-critically ill. There's insufficient data to recommend for or against using vitamin D to prevent or treat COVID. That's from NIH, updated as recently as July 17th of this last year. Zinc, insufficient data to recommend for or against to treat COVID, and recommend against using doses of zinc above the recommended daily allowance, dietary allowance, for preventing COVID unless someone's in a clinical trial. Next slide. Lancet had an editorial just published January 11th this year, bringing up the vitamin D controversy. And vitamin D supplementation extensively debated, strong arguments for and against. But during the pandemic, they stated in this editorial that it's long been clear that groups traditionally that exhibit vitamin D deficiency or insufficiency, such as older adults, nursing home residents, Black, Asian, minority ethnic populations are the same groups that have been disproportionately impacted by COVID-19. Next slide. Next. Vitamin D has multiple immunomodulating actions, favoring the ability of macrophages to mature and prevent them from releasing too many inflammatory cytokines and chemokines. It's also been shown to have favorable effects in numerous other viral infections. Next slide. There are plenty of studies out there showing some evidence for using vitamin D. Jane and his colleagues were evaluating deaths in ICU based on vitamin D deficiency, and they found the fatality rate was 21% with vitamin D levels less than 20, compared to only 3% for higher levels. He and his colleagues also found 97% of severely ill patients requiring ICU admissions were vitamin D deficient, but only 33% of asymptomatic cases were vitamin D deficient. De Smet and his colleagues in Belgium found 59% of patients with COVID-19 were vitamin D deficient on admission. So they became severe enough to need admission. And the deficiency on admission was associated with a 3.7-fold increase in the odds of dying from COVID-19, independent of other risk factors. Then we've got some older data from an Austrian study in 2014 of just ICU patients, that vitamin D supplementation cut mortality rate in half for ICU patients with severe vitamin D deficiency, and they used a cutoff level of 12 or less. Patients with higher levels did not show benefit. Next slide. So many of you, like me, have just wanted to pull your hair out with a lack of clear guidance, lack of recommendations. We all want to be able to do something to help our patients. And this editorial from in the Lancet just said we were basically all disappointed that in view of vitamin D being considered generally safe and that any potential low toxicity would likely be strongly outweighed by any potential benefits in relation to protection from COVID-19. They're just frustrated, as we all are, that our organizations, our leaders can't come up and say, well, this may not be harmful, why not try it? And France, they've done that already in all of their nursing home patients. Next slide. There's evidence linking vitamin D deficiency with COVID-19 severity. Yes, we know it's circumstantial evidence, but it is considerable evidence. The safety of vitamin D is so well established. Toxicity is not seen. Even when people supplement as high as 20,000 units daily over a prolonged period of time, that's meaning many months and years, there is a reported at least 40% prevalence of D deficiency in the US. And we know, yes, vaccinations are now available, but it's going to be months or even a year or more before everyone is, before we have widespread vaccination. Next slide. So if you decide to recommend vitamin D, we've got a lot of data that show vitamin D at low doses, 1,000 to 2,000 international units a day, is safe and not harmful. This is from an article in the Journal of Internal Medicine from Dr. Bergman. And he says this is consistent with our Hippocratic Oath, or our basic tenet of primum non nocere, first, do no harm. But potentially, we may prevent a number of acute respiratory infections and perhaps also COVID-19. Next slide. The vitamin D recommendations, if you do choose to use it, not from FDA, CDC, or NIH. 1,000 to 2,000 units a day is enough to keep the immune system healthy. Remember, I'm not talking about necessarily treating deficiency at that point. Small and daily doses are enough to boost the immunity. If possible, test your patients for vitamin D and provide the supplements to those whose levels are below 50. This will protect the bones and be enough to enhance respiratory immunity against acute respiratory infections. Next slide. Some others in the literature, and this this is an op-ed from MedPage Today. Dr. Carmona was the 17th Surgeon General for the United States, who's now the COVID guru at the University of Arizona. And some of his colleagues in public health put this op-ed out saying, don't let our COVID-19 patients die with vitamin D deficiency. We can't wait for perfect evidence. We need to act now. Their words, identifying and eradicating vitamin D deficiency with early and aggressive supplementation in COVID-19 has the potential to save thousands of lives and should be one of our highest public health priorities. Next slide. In an ideal world, yes, all health decisions would be based on overwhelming evidence, but a time of crisis may call for a slightly different set of rules. That's from the Lancet editorial. Next slide. So what are your take-home points from my section tonight? Ongoing communication with your staff and patients is really crucial. We can help them know that they're not helpless. They're not hopeless in this. We can help by focusing on preventing illness, vaccinate, continue wearing masks, social distancing, using good hand hygiene. Use this to help motivate patients for improved baseline health, because improved management of chronic medical conditions has been shown to decrease risk of getting COVID and of developing severe COVID. Our limited pharmacotherapeutic options are unlikely to change in the near future. Remember to anticoagulate only those with increased risk. Consider vitamin D supplementation. And don't forget to do what we already do. Continue to be there for our patients, leaders in our communities. Manage what we're able to manage, which is blood sugar, high blood pressure, heart failure, all those other things, smoking. Provide encouragement and support, not just to staff and patients during this, but remember our colleagues need some encouragement and support during this time also. The next slide. This is just the COVID-19 treatment guidelines.nih.gov is where all the most recent treatment guidelines approved by NIH are from. The AFP, the American Family Physician, had a good review put out in October that I recommend that kind of gives you everything. And then this is the third one is just a thought-provoking article from functional medicine, from the functional standpoint, from doctors Yannick and his colleagues about the phased immunological approach, because what we need in the early disease may be a bit different from what the long-termers are going through, what the long haulers are going through. All right, back to you, Dr. Van Dermy. Thank you.
Thank you, Dr. Weeks. So we'll dive into vaccines for the next 8-10 minutes, and we'll have time for some questions. So here's the status of how things got to where they are in the state of Florida. You can see the timeline there. On December 22nd is when the ACIP finally put out its recommendations for tiering or for scheduling who should get their vaccines first. The ACIP is the one who provides those recommendations for all of our vaccines. You want to know when to give an MMR or a polio vaccine or shingles vaccine, they all come from the ACIP. They've been doing it for decades, and those are the guidelines we followed. And so you can see that they started with saying that healthcare personnel and long-term care people should be vaccinated first, and then when they are covered, then go to those over the age of 75 and the other frontline essential workers, police and fire. And then when they are covered, then you move to 1C, which gets to people 65 and older and those with high-risk medical conditions, et cetera. The following day, the governors of a number of different states came up with a whole wide range of their own interpretations or their own modifications of this. And our governor said that we could only vaccinate, and the executive order uses the word only, long-term care residents and staff, people 65 and older with no restrictions in terms of whether they were at higher risk or not, and healthcare personnel with direct patient contact. As we all know, that's created a great deal of controversy. You know, we've had patients that were, profoundly multiple high-risk conditions and were 64, and we're not able to vaccinate them because we put it in the arm of a healthy, wealthy, hypochondriacal 65-year-old. But those are what the executive orders have for us, and those are the ones that we are required to follow. We then developed a huge problem over about a month's time in which we had vaccine tourists coming from up north where the rules were stricter, and they came to Florida to get their vaccines. And finally, just a couple of weeks ago, the Surgeon General released his public health advisory saying that every vaccine provider needs to ensure that the recipient is either a resident of Florida or they're coming here to provide healthcare. So healthcare professionals who came into the state could also get the vaccine. Despite a lot of vaccine hesitancy, and there is a lot of vaccine hesitancy, we still have a demand that is far, far greater than our supply. We also have an unpredictable supply source. We don't know literally from week to week how many vaccines may become available. And you may have seen in the news where they're trying to open the gates more and increase the supply to the various states, et cetera. Initially, there was a lot of mixed messaging in terms of whether to save the second dose. So if you got 100 doses, should you save them so that 50 people could all clearly get 2 doses, or do you give it to all 100 and hope that a second dose is coming? That rule has now changed. It's been made very, very clear that you do not save doses. You give everything that you can, and the suppliers will only provide you with dosing to match what you've already given. So if they gave you 500 doses and you've only put 400 of them or 200 of them in somebody's arms, then they're only going to give you 200 more to give second doses to those people. So bottom line is health departments, our facility, Dr. Weeks' facility, the hospitals and all that, if you've got it, get it into an arm as quickly as you can. Next slide. So we have 2 that are currently under, again, the emergency use authorization that we can use, the Moderna and the Pfizer. They both use this mRNA technology. For patients who thought that this is too new, too radical, how did you possibly do this so fast? The real word as we move forward in the 21st century is, why did it used to take so long for vaccines? It's not that, gosh, it should take 3 to 5 years to get a vaccine to market. We're going to look back in 5 years from now and say, why did it take them 5 or 7 years to get a vaccine back in the 70s or back in the 1990s or whatever? This mRNA technology has been around for quite some time. For decades, they've been looking at it with flu vaccines, rabies vaccines, and a number of others. So it is not a new concept. The vaccine is obviously new because COVID wasn't around, more than a year ago. What this does is it teaches the macrophage cells to make the spike proteins. So what we are putting into patients is coding instructions to tell the cell to make these spike proteins. It does not get into the nucleus of the cell. It does not mess with your DNA. It doesn't do any of that stuff. It simply goes in and tells the body, hey, macrophages, start making these proteins. And then when the spike proteins are there in our macrophages, then antibodies attack them, T cells get activated, et cetera, et cetera. It cannot trigger a positive COVID test because the antigen test and the PCR tests do not look for these same markers. So it's not going to give you a false positive on an antigen or a PCR. It doesn't change your DNA. It is not going to give you the disease. It's incapable of causing the disease. There is no virus there. All there is instructions to make the spike proteins. The CDC started a V-Safe program, a wonderful program for anybody with a smartphone, where it sends you a message daily. Have you been having symptoms? Have you had this? I've had my second COVID shot. I've got my COVID vaccinated button on here. And every day for the week after that shot, it says, have you had a fever? Have you had any symptoms, et cetera, et cetera? And then it goes to once a week. And when it's time for that second dose, it sends you a reminder. You should now be scheduled to get your second dose within the coming days, that sort of thing. People are reluctant. There is hesitancy. It's important to ask people why and address those questions specifically. Is this person worried because it's so new? Tell them that the virus is new, but the technology has been around for decades. If they're worried it's going to cause genetic changes to their baby, tell them, no, this does not affect the genetics, et cetera, et cetera. Next slide. So both of these, the Moderna and the Pfizer brands, say you should not get any other vaccines within 2 weeks of this. And it's simply because we don't know. It's not because it causes a problem, it's because we don't know. So I've had a few patients that had just gotten their shingles vaccine and said, nope, you got to wait another week before we can give you the COVID vaccine. So no other vaccines within 2 weeks. The grace period has been in there forever about you can give it up to 4 days before or after, if necessary, 21 days for Pfizer, 28 for Moderna. But just recently, the CDC has updated that. And what they have found is they still say, go with the 3 week and the 4 week. However, they have not found any drop off in the immune response if it's delayed for up to 6 weeks after the first dose. So there's debate right now of saying maybe we should make everybody wait 6 weeks anyway. The current recommendations are still give it on time as much as possible. But if that person was delayed for some reason, you had to give it at week 5 or week 6, you don't have to worry, you don't repeat the series. They recommend avoiding Tylenol, aspirin, etc. beforehand, simply because of the unknown. It might blunt your immune response. Take them afterwards if you got side effects, but not beforehand. The full immune response is found about 2 weeks after the second dose and found to be about 95% effective. Extremely high and something that gives a lot of us hope. The immune responses are common. We want to warn people of that. I always tell patients, I said, if you get that response, that's great. That means you got a terrific immune system. It's doing its job. So about a third up to a half of the people will have some headache, fatigue, feeling crappy after the first dose, and as high as 75% or more after the second dose. So good recommendation is to tell your patients to plan and look at your calendar and say, what am I going to be doing 4 weeks from now? And what am I going to do the day after my 4-week follow-up shot for Moderna or my 3-week follow-up shot for Pfizer? And don't plan on doing anything. Plan on saying, yeah, maybe at home, feeling flu-like and feeling crappy while my immune system is doing its job. The recommendations are to observe everybody for 15 minutes afterwards and 30 minutes if they've ever had any anaphylaxis to anything. So anaphylaxis to a bee sting, yes, they get a 30-minute observation, to peanuts, to anything like that. The actual anaphylaxis reactions are extremely rare, roughly 2 per million doses for Moderna, and I think 10 per million doses for Pfizer. But bottom line, very, very rare, but we do need to observe them. Next slide. So we'll talk a little bit of the details of Pfizer, what makes that one separate. That one is approved for a slightly younger age. They studied it down to age 16, 2 doses, 21 days apart. This is the one that's very problematic in terms of the storage issue, is you need an ultra cold freezer, way down at like minus 70 degrees centigrade for any long-term storage. And once it gets thawed up to refrigerator temperature, you've got 5 days. And we've been scrambling a couple of times here when they came out and somebody didn't show up and said, oh my gosh, we've got an extra 50 doses and they need to get in arms in the next 5 days or we have to destroy them or throw them away. And the reason for these short timelines is that none of these vaccines have any preservative in them. The mechanism of how the mRNA works is they don't put a preservative in it. So once it comes up to thawed, you've got to get it in quickly. It gets diluted with a saline, and then you get 5. It's made with 5 doses per vial, but what they found is if you use special syringes that have very little dead space volume in them, that you can regularly get 6 doses per vial. Once you have the diluent, you've got 6 hours. So you've got to get it in quickly. You've got to plan it up. And it makes it extremely difficult in the logistics. And I know I've been up to my eyeballs in them of trying to figure out, can I get the right people? I've got one more person. Do I break open a new vial for one? And then I'm scrambling to find 4 more arms to put the rest of it in, et cetera. Next slide. Moderna is for 18 and older, 28 days apart. Nice because it can stay in a regular vaccine freezer for long term. And when it gets up to refrigerator temp, it's good for 30 days. Don't need to dilute it. 10-dose vial. Also, once you crack open that vial and you stick your first needle in to draw out a dose, you got 6 hours to get those 10 doses in. Otherwise, they wind up going to waste. Next slide. Couple that are in the pipeline. Johnson & Johnson just today. So here's your breaking news if you didn't see it. Today, Johnson & Johnson presented its phase 3 trial results to the FDA to see if it can get approval for its single-dose vaccine. The good news is this stuff looks amazing that you can give a single dose, stable in the fridge for 3 months, would make the logistics of it unbelievably easier. It uses a type of vaccine that's been used for a number of other vaccines as well, using a modified benign adenovirus to teach it to make the spike protein. This one does get taken up in the nucleus. So everyone who is paranoid about whether their DNA may get changed, in theory, this could do this, but it doesn't. But I'm sure you'll see all over Facebook, don't take the DNA vaccine because it's going to turn you into a zombie or something. I don't know. It is not as effective. So the Johnson & Johnson vaccine is only reporting efficacy rates in the 70% range. However, in terms of giving it longer, so this one takes longer to take effect. 28 days after the vaccine, there were zero hospitalizations and 0 deaths from COVID. So to prevent the severe disease, it does seem to be very effective. It just takes longer because of its mechanism. Studies are ongoing down to kids to age 12. As we know, studies in kids are much more problematic. Merck canceled its vaccine plans because it wasn't working. Sanofi and GlaxoSmithKline started to try to make vaccine, found that they were not getting a response. They say they're putting theirs on hold or on pause. Merck said they just completely canceled it because they weren't getting the kind of immune response. Next slide. And I want to wrap up with, the vaccine, it clearly prevents disease, probably prevents mild cases. Reinfection is rare, but it can occur after infections. We'll learn more about these evolving strains and these variants. We don't know how long it's going to last is the bottom line. What we do know is we've got to get into a whole lot of people before we're really going to turn a major corner on this pandemic. We've got to get at least 70% of the population to have herd immunity to COVID. And just as a comparison, for measles, you've got to get about over 90% of the people immunized before you have measles breakthroughs. With this, it needs to get to at least 70%. Next slide. And variants. That's what I want to wrap up with some of the variants. So there are 3 that are floating around out there: the UK variant, South Africa variant, and Brazil variant. The UK variant now, as of today, Florida is #1 in the country. 1/3 of all cases of the UK variant in the United States are found in the wonderful state of Florida. It's now 5% and rising of the Florida COVID cases are from the UK variant. The vaccines do seem to protect against it. It's just not as strong a protection. And that's why they're working to tweak the vaccines to give us better response. The South Africa variant and the Brazil variant have both made it into the States as well. Problem with all 3 of these variants is they've been well shown to be much more contagious. Uncertain. We've got more data on the UK variant because we've known it longer, suggests that it might be more deadly, but that's on very early data on limited numbers of people in terms of whether it turns out to be more virulent that way. Next slide. So basic stuff, send your patients to CDC for good information. Tell patients that, yes, we are learning new stuff all the time, but we're not clueless. People get frustrated when we don't have definitive answers. Say it's a new disease. We don't know. We're learning it as we go along. And remember, keep up the mitigation strategies no matter what we do. And with that, we'll turn it over to Chris Scuderi and our president and others for some other comments.
Excellent. Thank you, Dr. Van Derby and Dr. Weeks. This was a fantastic, comprehensive, and timely review of a tough topic. And so we really appreciate you both being here tonight and sharing this information. We've got a little bit of time for questions and answers, and then I'm going to introduce Dr. Gross, and he's going to present some of the great work that FAFP has been doing over the past couple of weeks to support our members. So let me pull up the first question and just seeing. One of them is, can you comment on the concern that strain changes may affect PCR accuracy? Is there a better PCR test?
And the PCR test, there are different PCR tests that are out there. So different labs choose which viral markers they're looking for. So some labs say we're looking for these 4 markers or these 4 pieces of the virus. But all the PCR tests that are out there now do not rely just on a spike protein, which is tweaked in the variants. So all the PCR people are saying, yes, we can still pick it up just like the other ones because they don't rely on a single viral marker. The one that we do at FSU, we look for 5 viral markers to tell us that they've got the virus there. So even if one of them mutated, we'd still find it on the basis of the other 4 markers.
Excellent, thank you. Next question is there any data supporting the use of BAM therapy after 10 days Does this infusion affect the COVID-19 vaccine timing? Do you have to delay the vaccine?
Well, let me get to that. The data is not good yet about that, but it's been much more convincing, can you hear me, to use it early. So there is reason to believe that the efficacy decreases after the 10 days. And the vaccine should be delayed anyway, because you're only using this in a COVID positive patient, someone who's already had COVID. And the recommendation is still, the current recommendation is still to wait 90 days after the disease before getting the vaccination.
And 90 days past the infusion as well, exactly.
Correct, yes. It doesn't alter, it doesn't add any more to that, I guess is what I'm saying.
Yeah.
Thank you. We have a couple questions on colchicine. Has there been any recommendations for the use of colchicine in patients?
There are no official recommendations. That's it. People have tried it and it has been used in some areas, but no, the data is lacking.
And then there was another question about, can you comment on the use of the home pulse oximeter by a patient as a guide when to go to the hospital? Is there a recommendation such as a pulse ox less than 94% that we should give our patients if they have one at home?
There's no official recommendation out there. And of course, that depends on what the patient's baseline is. So if you have a COPD, it's going to be different from a healthy person. And so there isn't any official recommendation. Obviously, if they're getting down under 94% and they're a normally healthy baseline, then we're going to be concerned. But I know we have kept many people out, and pulse oximeters have flown off the shelves. If you didn't know that, many people have them at home now. We've monitored many people in the lower than that in the 90s. So it's a tricky question and no good guideline there.
The other issue with the home pulse oximetry is there's been a lot of stuff that's been out there about how inaccurate they can be.
Correct.
The minute you buy them off the shelf at Amazon, it tells you you're 88. You go to the hospital, you get a good one, and it says you're at 94.
96, yeah. So we still go a lot by whether someone is short of breath. Shortness of breath matters more than, I would say, the home pulse oximeter, unless you've got a known COPD or who's had their oximeter checked.
Is there any recommendations for a patient who develops COVID in between vaccine number 1 and number 2?
Yes, one of my patients right now is in the middle of that. And so, yes, the issue is you wait until the current COVID is completely resolved. And we push them out towards that 6 week. Now that we got the issue saying there's no drop in immunity after 6 weeks. So they then stay in their isolation period for those 10 days and give them that vaccine at week 5 or 6 as needed.
Thank you. There's a couple questions about steroid use. There's one that says COVID infection causes severe inflammation of blood vessels. Using steroids can reduce its effects considerably. Why is there such resistance to using them as soon as the patient is admitted to the hospital?
Well, that has a lot to do with that phase immunological response that's kind of beyond what we need to talk about here. And depending on, it hasn't been shown to be universally effective. But remember, we're talking about outpatient therapy right now. So I did not really brush up on all the latest about that. Some hospitals are very quick to start to put people on steroids, others less so. And I think the data is still coming in about that. I wish I could be a lot more helpful there.
A question here about the AstraZeneca vaccine. Is there any comments on the AstraZeneca vaccine?
And I did not mention AstraZeneca. My apologies, kind of can't cover everything in a talk like this, but the AstraZeneca one is still under review, and the FDA is not happy with the fact that there's a lot of unanswered questions, and that's been the problem with AstraZeneca and why it's taking so long. The issue is, we debate this on a whole lot of things, is the UK too lax in allowing it to go forward with limited amounts of data, or is the FDA in the US too strict in holding off because it's missing data that it wants to see? So it's been under a prolonged review with a lot of back and forth to say the FDA is not yet satisfied that it has enough information to move forward with the AstraZeneca vaccine.
Thank you. Received another question about the vaccines. It says, it is recommended not to take aspirin, NSAIDs, and Tylenol prior to vaccine administration. Why Tylenol? It has no anti-inflammatory properties.
Again, it falls into like so many things. It's the unknown. We don't know, because Tylenol is an antipyretic. It does lower fever. And the concept is maybe a slight febrile response from that first dose is a part of your immune system's building up its antibodies, activating its T cells, et cetera, et cetera. So that's their logic, is saying we don't want anything that might blunt a robust immunologic response to the vaccine.
And then received a question on what comments would you give to physicians who are negative about the vaccine?
My comments are this, and I'll paraphrase from a number of other webinars and other doctors who said the same sort of thing. And that's this: there is a lot that we don't know about this vaccine. There is. But the question is, do we know enough for a vaccine that is killing millions of people around the globe, that if you catch it, that depending on your age, your comorbidity and all that sort of thing, you've got a 1 or 2 or 3 or 4 or 5 or 10% chance of dying. If this was a vaccine for herpes, I'd say hold off on it. Herpes doesn't kill people usually, again, herpes encephalitis, blah, blah. But COVID is killing people, and say, do we know enough to say it prevents death? And maybe, just maybe, there might be an unknown risk down the road, but right here and now throughout the country, people are dying. That's my big response to docs. Now, I phrase it a bit differently when I'm talking to patients, because I want to be very sensitive to where their concerns are. Problems with communities of color. It's a very real problem of years of racism and a lack of trust in the healthcare community, et cetera. Those are very real issues, and I'll approach those differently. My big message to anybody is that if somebody says they're reluctant, ask them why. What is it that concerns you, so that I can answer your specific questions about mRNA is a brand new thing. No, it's not. That this vaccine has not been tested. Yes, it has. So, but to docs, I say, take a chance, because it kills. And I think that chance is tiny, and the risk of death is too real.
And it's not just, the risk of death is higher in those patients with increasing age, certain populations and comorbidities. But don't forget, there have been plenty of young healthies who have died from COVID.
You bet.
Thank you. I've got one last question before we finish up and go to Dr. Gross. This is, can you comment on COVID vaccine safety or an immune response for patients who've had bone marrow transplants?
So the issue on that is, don't know, but it's recommended to get it. So for a whole lot of the people who are markedly immunosuppressed, solid organ transplants, bone marrow transplants, et cetera, they fall into if you are at very high risk, if you get COVID, you're going to die. So they fall into this very high risk, and the recommendations by the major medical groups out there, CDC and many others, are to say that while it has not been well studied in these immunosuppressed people, et cetera, the risk of the COVID is so high that we recommend you get the vaccine.
Thank you. And just again, want to thank you both. This was an excellent presentation tonight. There's just so much great information that each physician can take back to their practice and just really help their patients. And so I just want to thank you both for a terrific presentation. It's greatly appreciated. I'd like to introduce Dr. John Gross, who is our current president of the Florida Academy of Family Physicians. He's going to give a couple updates.
Great. Thank you very much, Chris. I want to personally thank Dr. Weeks and Dr. Van Dermy. This was a great update. We had a lot of people on this webinar, and I feel like everyone's better because they spent time with listening to you guys. So thank you so much. Just a quick It's late. Just a 1-minute update on what the FAFP. So information about the vaccine that I think will piggyback on what we've heard tonight, and also what the FAFP is doing for family physicians in Florida. So this is from the Florida Senate Select Committee on Pandemic Preparedness Response. Keep on clicking. Go ahead and keep on clicking. From the 28th. So just some information, 1.7 million shots to date. And as I heard during the webinar, it's a supply issue. And, we hear it from the horse's mouth. If we had more, we could do more. And it's not just us, it's a nationwide thing. And nearly every state says it's about supply. So in speaking with the different CEOs, they say, 5 to 7 days is all that we can really look forward to what our supply is going to be. Can't plan past that. So we're hearing a lot about volunteering for vaccine sites and so on. And vaccine sites are abundant. It's just that we don't have the supply. And it's not about staffing. It's not about logistics. It's that demand exceeding the supply. The statewide vaccine appointment system is coming soon. In fact, got an email today that from actually the FMA giving some information about the appointment system being at the ready, county by county. And people, and it was alluded to during this webinar that there was a priority made towards seniors and there being a political bend on it. Surely it was, but ultimately it's a very difficult decision. In fact, this statistic here with 80% of COVID-related deaths in Florida being in seniors 65 and older, you can't ignore that. Unfortunately, politicians do pander to whoever votes. So policymakers did have to make some tough choices with that limited supply. We did get some questions about Publix. Why was Publix chosen? Because they were ready. That's the word from Tallahassee, is that Publix said, we're ready and here we are, and everybody else wasn't. And so my opinion is that I don't care, just Publix is widespread and should make availability easier. Next slide, please. So the FFP is advocating for you. PPE, early in the pandemic, Dr. Alexander made a Herculean effort to make sure that family physicians had PPE, at the very least N95 masks available. Dr. Scuderi has been a leader in putting together these webinars, which, if this is your first one, this is the standard. These webinars have been just over the top fantastic. And so to have this kind of open way of updating and getting this information out to family physicians has been amazing. The informational videos that we do post is out there for our colleagues as well as for patients. The FAFP.org website is a resource for family physicians for that up-to-date online information. In fact, most recently, it's been about where testing sites are going to be and where vaccine access locations are going to be. The FFP has been using Microsoft Word like crazy, and then putting it on official paper to governors and the Surgeon General to assist with how family physicians can assist with telemedicine, how we feel that simplification of different administrative tasks would lead to better care and better patient safety. We also made a big push to the CEOs of hospitals and large healthcare organizations throughout the state of Florida, pushing for vaccine access for unaffiliated community family physicians. We saw early on that only employed family physicians and other healthcare workers were being vaccinated. I truly believe that while we were one of the voices in a chorus to point out the fallacy of that, the conversations that I had and Jay's had throughout has, I think, made a difference as far as making it clear that all family physicians need to be part of this effort. And ultimately, we are bobbing and weaving. We are making, reacting and also trying to be proactive in how this COVID pandemic affects you as a family physician. And so know that we are working hard for you. And that's all I got. Thank you to our speakers. Thank you, Dr. Scuderi. I will turn it back over to you.
Thank you, Dr. Gross, for everything you're doing to advocate for us. So in conclusion, just want to thank everyone for joining us tonight, and not to forget to continue to visit the FAFP website, fafp.org, for late-breaking information concerning the COVID-19 crisis, and to listen to any of our past webinars. Most recently, the website has been updated to include a number of vaccine resources, including vaccine locators by county, and the newly developed Florida Department of Health Vaccine Locator. While there may be significant uncertainty ahead, one thing remains consistent: your FAFP's commitment to ensuring our members have the most up-to-date resources and information available. So please continue to read FAFP electronic communications and check FAFP.org for the latest updates. Once again, I want to thank Dr. Van Dermy and Dr. Weeks for just an amazing presentation tonight. It was just absolutely fantastic, and really just is, I think, a great resource to our physicians. So just thank you both. It's a lot of work into this, and just a lot of great information, and a lot of real-world information we can take back to our patients in practice. So we really appreciate you both. We appreciate the work that all the family physicians are doing on behalf of your patients in Florida and across the country. And we just want to ask everyone to save the date. We have a webinar tentatively scheduled for March 25th. The topics can be telemedicine in 2021 update, and it's going to be led by Dr. Julia Jenkins, who's been a leader in the state with telemedicine, and she's currently the chair of the AFP Telehealth Member Interest Group, and so she's putting together a great panel from around the country for this webinar. So we're excited for this. I know telehealth is important to all of us. So just want to thank everyone for participating tonight, and just ask everyone to stay healthy, stay safe, and we'll see you soon. Thank you.